Thank you again. So complete total occlusion is a term that came to us through the cardiology world. Coronary arteries have had lesions which are getting more and more complex as the coronary disease starts earlier and earlier in life. And just to point out that the coronary lesions are not the same as the lesions that we get in our patients. The atherosclerotic plaque is much softer, lipid-rich plaque without a whole lot of fibrosis. Compare this to a neointimal hyperplastic vein which has had chronic fibrosis, which eventually leads to a complete occlusion of that vein. Not the same disease, and the challenges are how do you deal with that. So over the next few minutes, what I'll do is I'll show you a span of different cases with different levels of complexities with complete total occlusion of either the peripheral or the central veins, and what I use to address those issues. So when you get a simple case, it's always welcome because a CTO in the central vessel can be a long case, as it was shown earlier in one of the things. It was a 3-hour case. So those are your long cases where you need to sweat to try and work on those. So this was a patient that we recently saw. Peripheral angiogram showed a tight basilic vein, swing side stenosis that was seen. But as you went through the central, you see a tight stenosis at the right brachiocephalic vein to SVC junction. And no dye would go through. You do see a right IJ catheter in the same location, and likely the stenosis is caused because that catheter is in that place. So this is a case where you attempt to pass the wire down into the SVC and it would not, but because you have the right IJ catheter, you could very easily remove that catheter, pass a balloon, open up that stenosis, and now you have a channel to angioplasty and open up that stenosis if needed. The best case in this would be if you leave that catheter out, but if your patient requires dialysis, and obviously this fistula was not mature to be used because of that peripheral stenosis that was present as well, we had to angioplasty the peripheral stenosis, angioplasty the central stenosis, and within 2 weeks, we got the fistula where it needed to be, where it was ready to be cannulated, and removed the central venous catheter. Like I said, the average case of venous complete total occlusion is a much longer case, requires a lot more equipment, a variety of different peripheral wires, guide wires, and different supporting catheters are required to work on these cases. So this is another patient that we saw, right arm brachial artery to axillary artery graft, came in with a clotted access, and on peripheral angiogram had a complete occlusion again of the right brachiocephalic vein. Looked further into it, you puncture the femoral vein to try and identify where is your target vessel where you want that wire to cross into. And when you superimpose the two images, you see your area of total occlusion. Now the length of this total occlusion has been suggested as a marker for seeing whether you can succeed in crossing that stenosis or not. And there are a variety of techniques that other people have suggested as to what can you use to cross it. Some general rules: there is a technique called the anchor technique where you position a balloon at the tip of that complete occlusion, and that kind of provides support to that wire, and you try and get the wire through a torque device through that stenosis. You could use supporting guiding catheters into the same location. That's another way of using it. This is what we did in this patient. We used a Miracle Bras 6 wire, and these are different wires with different weight at the tip of those wires, and there's a host of these wires available under coronary interventions ranging from 0.14 to 0.18 diameters, and what they have is a tip which is heavy weighted to help push through that tight stenosis. What you want to make sure is that any of the wires that you use, even the glide wires can be used for these purposes, have to be hydrophilic, because a stiffer wire or a hydrophobic wire tends to push through a wrong channel or a false channel and can create a perforation of the vein. Like in this patient, you could see the antegrade approach led to a false lumen, but when we went in from the retrograde approach, we were able to go into the right brachiocephalic vein and cross that stenosis. This is what we had essentially done in this patient, called a CAR technique, where you do an antegrade and a retrograde and see if you're able to cross that stenosis. And once you're able to go through, your next step is to make sure that you do a confirmation angiogram that you have gone through that stenosis. And at that point, once you confirm that you are in the lumen of the vessel, you would angioplasty and perform a stent if needed. Now, stents are not required in all patients, but in most of the patients, if there is a complete occlusion, especially in the central vessels, you may require a stent. This is another case that we just did. This patient already had a stent in the left brachiocephalic subclavian vein with a complete occlusion. Comes in with an arm swelling and high venous pressures. So you see there is no flow going into an old, this looked like a wire band stent, and there was another stent in the more proximal vessel which looked like a wall stent. Tried to pass an 035 wire, would not go through. And this one we used an 018 wire, which was able to cross that stenosis after several attempts using the torque device and using the stiff end of the glide wire, because we were in the covered stent area, so I was more confident about not perforating through the vein. Once you're through that stenosis, again, your next step is to make sure that you push your guiding catheter through that path and make sure that you have access into the more proximal venous segment. At that point, you would do controlled angioplasty using a small balloon to create the path for a bigger balloon, angioplasty with a 12 millimeter balloon. And after that angioplasty, we saw that the flow opened up into the distal wire band stent, but the wall stent remained disease-free, probably because there's a lot of mesenchymal tissue that has grown into that area. So you need to put another stent into this 2-stent patient already, or abandon that access. So here's where we put another 13 by 10 centimeter wire band stent, and you have excellent flow through that central vessel after the case. Sharp needle recanalization is another technique that has been introduced and reported and being used more and more in literature. A recent case reported by Dr. Bethard illustrates this technique very nicely. So you have a patient who's got a radiocephalic fistula. The cephalic vein is 100% occluded. You see a lot of collaterals draining through that area. And if you follow those collaterals, you see them draining into proximal basilic vein that fills up and is the main outflow channel through the fistula. But there is no flow going through the channel, and repeated attempts to pass a wire through that stenosis fails. So it's 100% complete total occlusion. At that point, they cannulated one of these collateral vessels and say, oh, if maybe we can go retrograde towards that inflow channel, and they were unable to do that, and it caused extravasation and a tear in that collateral vein. So at that point, they decided you had an option of either creating a secondary fistula, a type 2 secondary fistula in the upper arm, or maybe try and do what they call the sharp needle recanalization. So you know where the target is. You could put a target balloon, a snare, into the more proximal target vein, pass a wire through that. Now you've got a through and through wire into that channel. You'll dilate that channel, put a covered stent across it, and you've got a working fistula in the forearm. So again, a more advanced technique that can be used to get a fistula going, which otherwise would have been abandoned. And unless there is a better fistula that you could create, this may be a way to salvage that fistula. So the three basic steps for sharp needle recanalization. You have a sharp needle that would cross that complete occlusion. You dilate the tract with an angioplasty balloon, and you will need a stent graft because you are going extravascular when you cross that lesion in this particular situation. There's another example of a sharp needle recanalization for central catheter placement. So here's a patient who's got a complete right IJ occlusion, no flow through that, a bunch of collaterals. You would use a sharp TIPS needle, cross that lesion, dilate that tract, and go ahead and put a catheter. So TIPS needle has been traditionally used for coming out of the hepatic circulation into the portal vein circulation, and once you're able to aspirate that tract, and it's a sharp needle with a over the needle catheter that passes into the portal circulation. Once you confirm you're in the portal circulation, you'll dilate the tract and put a stent, which forms a channel between the portal and the hepatic communication. So the similar concept is used for canalization of certain chronically occluded central veins. Complex systems, I've never used it, but has been reported in the literature. More advanced, you could certainly use radiofrequency ablation catheters. Now, radiofrequency ablation catheters are basically high frequency waves that will pretty much just melt any occlusion or a fibrotic lesion like hot knife would melt the butter. But because it's so invasive, it would have a high risk of complications if the perforation rates would be a lot higher to cross that stenosis. But the good general goal is that you would cross that lesion, and once you cross the lesion, you have your angiographic catheter in the more proximal vein. You confirm your location and then dilate in any required fashion. So in summary, the CTO techniques is more advanced. The time, the energy, and the equipment required is certainly more higher skill levels, and it needs to be done in a more careful setting, certainly not in an outpatient center where we do not have ways to intervene in case there is a major complication. You want to make sure that you do have cardiologists or surgeons who have used this technique in the past, and in my case, I've done a few of these cases with a cardiologist to begin with, and then with vascular surgeons, and that always helps to ensure that you're able to have somebody by your side if there were problems that you would encounter in these cases. Prepare for unexpected and complications that can come in when you do these procedures, perforations, hematoma, rupture of the central veins, and make sure that you do have baling stents, covered stents in this situation. The biggest covered stent you would get would be a 13 millimeter wire band stent, so you have to make sure that your anatomy is suitable for such an application before you start attempting opening that vessel. And then you will need a variety of different wires to try and play with to get through that lesion. Now, which of those techniques works for you? And I did not go into details of certain other more advanced wires and techniques that are available, predominantly used by cardiologists for the re-entry techniques and other ways, maybe not applicable to our patients because of the nature of the lesions that we see in our patients. So having said that, I introduce you to New Orleans, which is where we will be hosting the next ASDEN meeting. New Orleans is the party town in United States and Louisiana. Mardi Gras and Bourbon Street is what makes it famous. The party goes on pretty much the entire month of January and February, culminating with the Ash Wednesday. And it's known for chefs and food. John Besh, Paul Prudhomme, Emeralds are all from New Orleans. So I invite you to come and attend the ASDEN meeting this year, which is in February next year, and will be in New Orleans. So with that, thank you so much again for inviting me and giving me the opportunity to be here, and I'll take questions.
Thank you, Dr. Sachdeva, for giving us how to really tackle difficult problems. But I think, as I think all of us know that what needs is commitment, a passion, and a will. So when you have the will, you'll find some way to conquer these difficult situations. The house is now open for any comments, questions.
Dr. Sachdeva,
Yes, sir.
what is the success rate of your technique? Does it depend on the duration of occlusion? Means how late the patient presents?
So the duration of occlusion is sometimes hard to know because these patients come in with a swollen arm or some dysfunction of the fistula, but the stenosis may have been present for a while. Most of the cases that you see with central total occlusion will have a lot of collaterals, like the patient that we saw with complete stent occlusion, and those collaterals keep the access flowing. So this is usually a more chronically occluded lesion. The success, in my opinion, has been somewhere about a 50%, 50 to 60%. So of all the cases that I've tried, about 1 in 2 you're able to get through and pass a wire, and the others you may not be able to do that. And that's where perhaps you have to keep pushing the boundaries and start using equipment and wires like a radio frequency ablation wire, and I've never used that. But in certain cardiology labs, if that's available, that would be another way to cross that lesion, although you have to recognize that there may be a higher risk of those complications with perforations that can occur in those situations. So yes, it's not something that is easy. It's not perfect, but in a patient, if you're able to salvage that access, it saves and take care of the swollen arm, and they do not have other ways where you can create a fistula for them. That would be a way to solve the problem. Now, if they have a good vein in the secondary arm and you can create a secondary fistula, then you can go back and ligate that fistula once that other fistula starts working, and that would be a way to solve the problem.
What is your success rate in these total occlusion?
Say it again?
What is the success rate of interventions for these totally occluded lesions?
As I said, for in my personal, about 50-60% of these are successfully recannulated. About 30-40% of them are not amenable to angioplasty. And I think the biggest series I came across was about 10 patients or 12 patients. It's not very common lesion that we see. Now, having said that, even for coronary vessels, the attempted recanalization or intervention is done only in about 50 to 20% of the patients who do have CTOs. So that's another thing, that we do have, the interventionalists who see complete occlusions but are not attempting a possible intervention, which could be successful in about 1 in 2 cases.
When you will give up this stage, you cannot do any intervention, you will stop that. At what is the time period or something, how will you assess that?
I think it all depends on your level of comfort with those occlusions, and if you have tried all the techniques that you know of and then you cannot get through, then at that point you'll have to give up. So yeah, I cannot say that you have to try for 15 minutes or 20 minutes. I guess it's about you knowing what you have achieved and what you've done, and if it doesn't work, then yeah, at some point you have to say no.
So for the any question.
That's a very good question. What is the recurrence rate? So if it is a central vein occlusion and you do an angioplasty alone, the recurrence rates are very high. The primary patency for central vein angioplasty is less than 10% at 1 year. So you have to put a stent. Even with stents, the patency is less than 40-50% at 1 year. So yeah, these lesions have high rate of recurrence. There is some evidence that putting covered stents does decrease the risk of recurrence. So that would be the care that I would provide these patients. If you're able to recanalize these vessels, you would angioplasty and put a covered stent.
Okay. I said one information, Government of India has announced that 275 district headquarters centers is going to be this dialysis centers. Definitely in future days, these type of problems will come in very frequently. We need to be trained in this angle.
As the dialysis population becomes longer prevalence on dialysis, that's when we see these complications a lot more.
Hi, thanks. Enjoyed the whole talk. Just to put it in perspective, as a nephrologist in a level 2 city, you are coming from a center or a state where maintenance dialysis has been going on for decades. What is the expected caseload or dialysis load to produce 10 such patients? And what is the expected need for a nephrologist working to be having to deal with this? Are we trying to create a situation where everybody will try to become an interventional nephrologist of this degree? Or should we make centers of excellence and others to have standard reference patterns? Because volumes would drive the quality and results.
Absolutely, and I think volume has been always associated with success of any procedure. Whenever there is a hands-on procedure, if you're doing one case a year versus one case every month, your success is going to be a lot different. So to set up and try and attempt these procedures, as I said, you have to have partnerships with others who have had more experience in their fields, vascular surgeons, cardiologists, who have used those wires, those techniques in other situations, and you tag along with them. One of the papers about coronary CTO suggested we need to form local CTO clubs within your institutions, and if you have such things, that's where you start, you plan that intervention, you study that patient, and then do a few of them in conjunction with others who have done them, and then at that point start doing them some on your own.
Just to tease it a bit more, like LSU must have a dialysis unit treating.
So we have about 1,200 procedures a year, and we see about one total occlusion every month on an average, I would say.
Out of 1,200 a year.
Out of 1,200 total a year. So we do about 0.01% of the total cases are complete total occlusion. So not a very common problem, but in a given patient, that N is 1, and for that patient,
Agreed.
Can you solve the problem or not? That's the big question.
Agree. I said 1 versus population.
Right,
Thanks.
right. It's not very common.
Thanks.
No.
We close the session.
Yeah, thank you very much, Chairpersons and Dr. Sachdeva.